So dysrhythmias can generally occur from 4 areas: either the abnormalities or originating from the SA node, or originating from the atria, or the AV nodes, or from the ventricles. So we'll talk about all of this one after the other. So for rhythms that originate from the SA node, first we'll talk about the sinus bradycardia. Here, there's a heart rhythm. A heart rhythm is initiated in the SA node at a rate of less than 60 beats per minute. Usually, this can occur normally in athletes or during sleep. Treatment is with the use of atropine or pacemaker therapy. So this is an ECG strip showing sinus bradycardia. It's sinus because all the waves are there as they ought to be, but the problem here is that the rate is slow, so it's sinus bradycardia. So you can see the P wave there, the QRS complex, the T wave, and you can even see that this P wave is in about 4 small boxes. So that is normal, because we said it should be, sorry, the PR interval I'm talking about now, we said it should be between 3 to 5 small boxes. Hello, can you hear me? Hello?
Yes, yes, we can.
Okay. But when you now count the rate at of this ECG strip now, so assuming this is a 25 millimeters per second strip, we can use sorry, Chief, I can't hear you.
Because we can't hear. Okay, Ehireme, continue, Sha.
Okay.
Maybe he'll try to tell us what he's trying to say.
Okay. So, assuming there are many ways that you can use in calculating the rate of of the heart rate in an ECG. So we can use, let's use 2 methods in this ECG now. We can use the 6-second rule, or we can use the one where we have to divide the 1,500 by it. So using the 6-second rule now, we know that the one tiny box is 0.04 seconds, meaning that 5 small boxes will be 0.2 seconds. That means an accumulation of 5 large boxes. So one large box is 0.2 seconds. 5 large boxes is 1 second. So in this ECG, there are some ECG strips that come like this. It has this thick dark lines up here. These thick dark lines are drawn after every 3 seconds. So from this line to this line is 3 seconds, and from this line to this other line is 3 seconds. So we have 6 seconds on this strip. Now you can just simply count the number of P waves or the number of R intervals we have within the 6-second area. So for this strip now, we have 1, 2, 3, 4. We have 4 R waves. So we can say that, and you have to multiply the 4 by 10, because if this is 6 seconds, 6 times 10 makes 60 seconds, which is 1 minute. So 4 times 10 is 40 beats per minute. So we have this ECG strip now, the rate here is 40 beats per minute. So that is sinus bradycardia. Everything is normal. The only problem here is the rate. The second one we'll be talking about is sinus tachycardia. Here, the rhythm is initiated in the SA node at a rate greater than 100 beats per minute. Occurs normally in exercise, stress, or anxiety. Treatment is based on the underlying causes. Then sometimes when you treat hypovolemia, it also helps to resolve associated tachycardia. In certain situations, you could use adenosine or beta blockers to decrease the heart rate. So this is an ECG strip again. So using the same method, we can just use from these two black lines, from this first black line to the second black line is 6 seconds and about 30 large boxes. So just simply count the number of R waves you have within there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 times 10, 120 beats per minute. Even if you say, let's count the small boxes. So let's use between this and this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So about 13 small boxes. So if we say 1,500 divided by 13, that's about 115 beats per minute. So we have a sinus tachycardia because you can look at the ECG strip and you can see the P wave, you can see the QRS complex, and you can see the T wave. Normal. Only problem here is the rate. So this is sinus tachycardia. We move over to sinus arrest. Here, the SA node the SA node's automaticity is decreased and the impulses are not formed when expected. So what happens is that there's an absence of the P wave, the QRS complex, and there's no electrical activity for about 2 seconds. Treatment is with atropine 0.5 to 1 milligrams intravenously, which helps to increase the heart, or pacemaker therapy. So you can still see it on the ECG strip. We said five large boxes is 1 minute. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So about 2 minutes. So you can see there's no electrical activity at this point for about 2 minutes. Now, what usually happens in sinus arrest is the SA node could begin picking up again on its own, or if it lasts a few seconds, any other part of the heart will take up the role of the pacemaker, either the atria or the AV node, usually the AV node or the Purkinje fibers can take over the role of the pacemaker. So for rhythms that originate in the atria, the first one we'll be talking about is atrial flutter. Here there's a single atrial ectopic focus that fires at a rate of 250 to 350 beats per minute, and it results in a ventricular response that is slower, usually a multiple of the atrial rates. You know that we said at the AV nodes, it's like a rate limiting step. So impulses that travel to the AV nodes are regulated and slowed down because the inherent ability of the AV node fires about 40 to 60 beats per minute. So definitely, when these impulses are coming from the atria, it's not going to continue in that high rate. It's going to be slowed down at the atrioventricular node. So in atrial flutter, you see the P waves are replaced by flutter waves. They look like sawtooth appearance. Treatments can be done with calcium channel blockers, beta blockers, or cardioversion. Cardioversion is a procedure where they put some electrodes in the heart and electrical impulses are passed through electrodes on the chest, and the electrical impulses are passed through those nodes to help reset the heart. So this is what it looks like on the ECG. You can see the P waves looking like sawtooth appearance. The next we'll be talking about is atrial fibrillation. It is an abnormal reading that originates from multiple ectopic focus in the atrium. Remember, in atrial flutter, it was a single ectopic focus. In fibrillation, there are different areas of the atria that have begun to do the work of the SA node. So they are now firing electrical impulses on their own. And so there's a disorganization of the normal conducting pathway. There's a disorganized switching of the atria. Usually the rate is greater than 300 beats per minute. The rhythm is irregularly irregular. This is the hallmark of the dysrhythmia. The atrial fibrillation may occur paroxysmally, but it often becomes chronic, and it could occur in COPD, congestive heart failure, and other heart diseases. Treatments can be done with calcium channel blockers like diltiazem, beta blockers like metoprolol, digoxin, amiodarone, or with the use of cardioversion. So this is what it looks like on the ECG. You can see the P waves. In atrial flutter, they look like sawtooth. Here, they look more disorganized than sawtooth appearance, but you still see the Q RS complex. However, the rates, you can see even by looking at the RR intervals, you can see they are not, it's not regular. The spaces in between them are different. So the third one we'll be talking about, rhythms that occur in originate from the atria, is paroxysmal supraventricular tachycardia. Here, the dysrhythmia is originating from an ectopic focus anywhere above the ventricles, and the rate change is usually abrupt and unexpected. The rate here is between 140 to 250 beats per minute. The rhythm is regular. Then the P waves are buried usually in the preceding T waves. So you might not be able to distinguish P from T waves. And then the QRS complex may be normal or narrowed. So this is what it looks like. So you can see a P wave, QRS complex. You can't really distinguish the P from the T waves. So the P is usually buried in the T waves. But you can see that the RR intervals are regular. So the causes of supraventricular tachycardia include stimulants like alcohol, caffeine, tobacco, or during exercise. Also could be as a result of sepsis, stress, diseases like coronary artery disease, congestive heart failure, COPD, myocarditis, rheumatic heart disease. Treatment can be done with the Valsalva maneuver, which will help to increase vagal tone and hence reduce the rates, the heart rates, or can be used with, we can use beta blockers or adenosine. Signs and symptoms, you can use the acronym collapsed for, in fact, for many of these arrhythmias, they will present with this same similar signs and symptoms, including chest pain, low oxygen, that's low SpO2 levels, low blood pressure with tachycardia, lethargy, anxiety, palpitations, shortness of breath, elevated ventricular or heart rate, dizziness, or syncope. That's the acronym there is collapsed. So rhythms originating from the AV nodes or AV junction. So the first one we'll talk about is the premature junctional complex. Here, there's an ectopic beat that originates from a site in the AV node that is outside of the normal cardiac cycle. And it occurs early before the next normal impulse. The rhythm here is mostly irregular. P wave is usually absent, inverted, or buried. The PR interval is either non-existent. If there is no P wave, there will be no PR interval, or if it is, it may be shorter than we expect it to be. That's shorter than 0.12 seconds. The QRS complex is normal. Causes just like paroxysmal supraventricular tachycardia is stimulants like alcohol, caffeine, tobacco, exercise, sepsis, stress, hypokalemia, hyperthyroidism, digoxin toxicity, diseases like coronary artery disease, congestive heart failure, COPD, myocarditis, rheumatic heart disease. So just simply treat the underlying cause. So for the AV disorders originating from the AV junction still, we have junctional escape rhythm. Now, remember we had the sinus arrest. Junctional escape rhythm can occur when sinus arrest persists for too long. So it usually occurs when the atrial rate is slow, usually less than 30 beats per minute. The atrioventricular node then assumes the responsibility for pacing the heart at a rate of about 35 to 60 beats per minute. Usually, because the inherent rate of the AV node is 40 to 60 beats per minute. So it usually helps to helps to pace the heart rate at that between 40 and 60 beats per minute. Rhythm is usually regular. Then the P wave will be absent, of course, because it's not this impulse is not coming from the SA node. So it's not going to contract the atrial before getting to the AV node. The AV node is now the pacemaker. So P wave will be absent, inverted, or buried since the atria is not fully contracting. The PR interval might be absent as well or may be shortened. QRS is normal. So other types of junctional rhythms. Now we could have accelerated junctional rhythm. Here the ventricle is now compensating to increase the heart rate and possibly the cardiac output. So in accelerated junctional rhythm, the heart rate is between 60 to 100 beats per minute. Then it could also progress into junctional tachycardia where the heart rate is greater than 100 beats per minute. So in junctional tachycardia, it occurs when the AV node becomes irritable and overrides the sinus impulses, becoming a primary pacemaker at a rate of greater than 100 beats per minute. Causes, so especially the junctional escape rhythm, it could occur as a result of drugs that can slow the heart rate, like beta blockers, calcium channel blockers, or digoxin. Myocardial ischemia, myocarditis, sepsis. The symptoms of junctional rhythms, also just like previously discussed, you can use the acronym collapse, chest pain, low oxygen, low blood pressure and tachycardia, lethargy, anxiety, palpitation, shortness of breath, low heart rate, and dizziness or syncope. Treatment: discontinue the drugs that are slowing the heart rate. And if the patient has symptoms of escape junctional rhythm, you can use atropine to increase the heart rate. If there's accelerated junctional rhythm or junctional tachycardia, you can now further reduce the heart rate with beta blockers or calcium channel blockers, or you can use amiodarone. So this is what the ECG looks like. Remember that we said that the P waves are absent or they are inverted. So you can see an ECG strip where you just see this straight line up until you get to the QRS complex. That means there's no P wave. Or when you see this, the P wave here is inverted. But you can see it looks like a sinus rhythm because you can see the RR interval is regular. But the problem here is this inverted P wave. So this is a junctional escape. And when you also count this the space between, when you count the heart rate in this ECG, you also realize that the heart rate is less than 60 beats per minute. The difference between this and junctional accelerated junctional accelerated junctional rhythm is, in accelerated junctional rhythm, when you count the heart rate, it will be between 60 to 100. And then in junctional tachycardia, the heart rate will be greater than 100. But you still have the same picture of inverted P waves or absent P waves. First degree atrioventricular heart block. So we're still talking about rhythms that occur from the AV nodes. So here, the impulses are unable to travel through the AV node as expected. So the impulses originates in the SA node, but has prolonged conduction through the AV junction. So meaning that the PR interval is going to be prolonged because it takes some time for the atrium to contract and then to transmit the impulse through the atrioventricular node into the ventricles. So the PR interval is going to be prolonged. This is the hallmark of AV blocks. The rate is variable. The P wave is normal. QRS complex is normal, but the PR interval is prolonged. It is the most common conduction disturbance, and it occurs in both healthy and diseased hearts. The rhythm is regular. First degree AV block can occur as a result of inferior MI, digitalis toxicity, hyperkalemia, increased vagal tone, acute rheumatic fever, myocarditis. Intervention include treating the underlying cause, observing for a progression to a more advanced AV block. So you might just watch, no need for drugs per se, but you have to treat the underlying cause. So this is what the ECG strip looks like. You can see from this P wave, this is a T wave, from this P wave to this to the beginning of the Q, that's the PR interval here, you can see it's more than 5 small boxes, meaning that it is prolonged. You said that the PR interval should be between 0.12 to 0.2 seconds. 0.2 seconds is 5 small boxes. So it is greater than 5 small boxes, it is prolonged. So if you look at this other one, they are all prolonged. So this is first degree AV block. Now there is a second degree AV block. It's also called the Wenke-Bach or Mobitz type 1. Here, the AV, here this in second degree AV block type 1, it occurs in the AV node above the bundle of His, like we've said before. The conduction in the conduction pathway, the PR interval is progressively longer until one P wave is blocked, and then the cycle begins again following the blocked P wave. So what this simply means is that you have PR interval that is more than 5 small boxes, and then the next one is even more than that. So you see the PR intervals, it continues to increase, it continues to get longer until you see a P wave and then there's no QRS complex. So that's Mobitz type 1, second degree AV block type 1. Here the rate is variable, the P wave is normal, even the PP interval is normal, the QRS is normal, but the PR interval is prolonged and the reading is also irregular. It is often transient and may be due to acute inferior MI or digitalis toxicity. Treatment is not indicated as this reading usually produces no symptoms. Second degree AV block type 2. This block occurs below the bundle of His and may progress into a higher degree block. The rate is also variable. The PP intervals are normal. The QRS complex is widened because it is associated with a bundle branch block. The PR interval may be normal or prolonged, but it is constant until one P wave is not conducted to the ventricles. So the difference between type 2 and type 1 is just that in type 1, the PR intervals are progressively getting longer until you see a P wave and you don't see a QRS complex. So that's to say that the impulse was not propagated into the ventricles. In type 2, which is more dangerous, it's almost as if in type 1 there's a warning. It's giving you a warning like the PR interval is getting longer and then it drops a QRS complex. In type 2, there's no such warning. The PR interval may be normal or prolonged, but it just does not conduct into the ventricles. You still see that there's a drop in the QRS complex. So that's the difference. The reading is usually regular when AV conduction ratios are constant. It can occur after acute MI or due to damage in the bifurcation or the bundle branches. It is more serious than the type 1 block, and treatment is with a pacemaker. So this is what we are talking about. So you can see a P wave, QRS complex, T wave. Then you see a P wave, no QRS complex. You see another P wave, no QRS complex. So this is type 2. Now the third degree AV block. Here, the atrial and the ventricular activities are unrelated to the complete block. Sorry. Here, the atrial and the ventricular activities are unrelated due to complete blockage of the atrial impulses in the ventricles. So there's a complete block at the AV node. So atria is contracting on its own, ventricle is contracting on its own. Everybody is doing their own business independent of each other. So the complete block, or there's complete block of the atrial impulses, which occurs at the AV junction, the common bundle, or the bilateral bundle branches. Then another pacemaker distal to the blockage takes over in order to activate the ventricles, or ventricular standstill will occur. So the atrial rate is usually normal, ventricular rate is usually less than 70 beats per minute. We know that the atrial rate is always faster than the ventricular rate, as we said before. There's normal or constant PP intervals. Even the RR intervals may be normal or constant, but it is not married to the QRS complex. You don't see that normal rhythm of P wave preceding a QRS complex. You can see P, P, QRS, P, QRS, QRS, you know, but the PP intervals is usually normal. RR intervals usually may be normal as well. QRS intervals may be normal or widened depending on where the pacemaker is located in the conduction system. The rhythm is irregular and may be caused by digitalis toxicity, acute infection, MI, degeneration of the conductive tissue. Treatments include pacemakers, use of atropine, and permanent pacing can be done for chronic complete heart block. So this is what the ECG strip looks like in complete heart block. You can see a P wave, QRS complex. Sometimes the P and the T waves are overlaps as well because of the independence in both the atrial and the ventricular contractions. P wave, QRS, P, QRS. So they are contracting independent of themselves. But one thing you can notice here, you can see the PP intervals. PP intervals are regular. And even the RR intervals are also regular. Next is the right bundle branch block. This block occurs in the right or left bundle branches or in both. The ventricle that is supplied by the blocked bundle is depolarized abnormally. The left bundle branch block is more ominous than the right bundle branch because it is usually present in diseased hearts. Both may be caused by hypertension, myocardial infarction, or cardiomyopathy. A bifascicular block may progress to a third-degree heart block. The rate is variable. The P wave here is normal if the underlying rhythm is sinus. The QRS complex could be widened greater than 0.12 seconds. The rhythm may be regular or irregular depending on the underlying rhythm. Treatment is with the use of artificial pacemaker for a bifascicular block that is associated with acute MI. This is what the ECG strip looks like. Now we move on to rhythms that originate in the ventricles. First, we'll talk about the premature ventricular contractions. Here, there's an ectopic beat originating from a site in the ventricle outside of the normal cardiac cycle. Some people call it ventricular sneeze. So it's like the ventricle just contracts on its own outside of the normal pathway. So the rhythm is irregular when the PVC occurs, when the premature ventricular contraction occurs. The QRS complex may be wide and bizarre. The causes are similar to those of the PJC, that's the collapse acronym. For premature ventricular contractions, treatment may be with the use of beta blockers, procainamide, amiodarone, or lidocaine. Ventricular fibrillation. When a premature ventricular contraction falls on a T wave, it may precipitate a ventricular fibrillation. Here, the dysrhythmia results in absence of cardiac outputs because the rate is so fast. The rate is unattainable. The P wave may be present, but it's obscured by the ventricular waves because the ventricles are contracting in a very haphazard fashion and also in a very fast rate. The QRS complexes is not apparent. Conduction there's chaotic electrical activity, and you see shapeless oscillations. So the clinical features, because the ventricle is contracting, but it's not filling up enough to be able to deliver adequate cardiac output. It's just contracting so fast at a very fast rate. It's like somebody who's is not being supplied with blood. So you definitely notice that this patient may lose consciousness within seconds. There's no pulse. The respiration may also cease. It almost always occurs with serious heart disease, especially acute MI. The course of treatment for ventricular fibrillation includes immediate defibrillation and commencement of ACLS protocol. So we'll have to commence CPR for these patients. Identification and treatment of the underlying cause is also needed. Now, there's a syndrome called the Wolff-Parkinson-White syndrome. It's a congenital condition which is caused by abnormal myocardial connection between the atrium and the ventricle. Remember that we said that there's an annulus fibrosis separating the atrium from the ventricle. The only place where impulses are normally supposed to travel from the atria through the ventricles is the through the AV node. But in this syndrome, there's an abnormal myocardial connection between the atrium and the ventricle. So the AV node can be bypassed and conducted, and the impulses are conducted quickly over the abnormal connections. The ventricles then depolarize abnormally because the bypass lacks that rate limiting properties that the AV node has, and then the patient is at risk of ventricular fibrillation. We'll move over to rhythms originating in the ventricles. So,
sorry, Dr. Ehireme,
yes.
Please, can you stop rushing? You are talking too fast. I don't know, maybe because
really?
Time is almost up, but just calm down.
Okay, sir. Should I go back?
So just continue from where you are.
Okay. So for ventricular tachycardia, it occurs when there are 3 or more consecutive premature ventricular contractions. Here, the treatment is for hemodynamically stable ventricular tachycardia. When there's a pulse, you can use amiodarone or lidocaine. When the patient is hemodynamically unstable in the presence of ventricular tachycardia with a pulse, you can use cardioversion. So you can transmit electrical impulses through electrodes on the chest to help reset the heart. When there's a pulseless ventricular tachycardia, you have to defibrillate the patient. So this is what the ECG tracing looks like. For premature ventricular contractions, ventricular tachycardia, you can see there's no rhythm. The ventricles are just contracting at a very fast rate and obscuring every other contractions going on, or electrical impulses going on in the heart. Then for the ventricular fibrillation, you can basically see that there's almost, you can't make sense out of the ECG tracing. Ventricular standstill or asystole. Here, it occurs usually following termination of the atrial, AV, junctional, or ventricular tachycardias. However, the pulse might be insignificant because the heart may resume beating on its own. But asystole that lasts for a long duration in the presence of acute MI and coronary artery disease is usually fatal, and you may have to commence CPR, or you may have to place the patient on atropine, or have to put a pacemaker for the patient. What happens here is that there's no use. The ventricles just stops beating. There's no rate. No, the P wave may be there, but the ventricles are not responding. So therefore, definitely there will be no QRS complex. This is what it looks like. So you can see some small elevations on the ECG strip, the small elevations that might be indicating the P waves, but you don't see any QRS complex. So the ventricles are not contracting at all. So in conclusion, Cardiac dysrhythmias can range from benign to life-threatening types. The recognition and subsequent management of cardiac dysrhythmias is key to prompt management and therefore preventing complications and ultimately death. Prevention of dysrhythmias. You can use these patients have to be mindful of their lifestyle, ensure that they take proper diet, stop smoking and limit alcohol and caffeine, exercise, healthy weights, manage their stress levels, keep their BP in control and cholesterol under control as well. Thank you. These are my references.
And thank you, Dr. Ehireme, for this detailed intellectual presentation. It was a wonderful presentation. But immediately you started the presentation, I now realized what a tough topic we gave you. But we'll take questions, comments, and clarifications. House, are you awake?
Yeah.
So, House, let's take comments, clarifications. For me, Dr. Hireme, very wonderful presentation. I now
Thank you,
see
ma.
what Dr. Ichado was saying you were running, because is a tough thing to what will I say, um
Explain.
to explain and for it to enter our heads. So like most of all the strips, all the ECG, like that, the fact that I gave a lot of examples of the ECG strips of all the conditions. But so maybe thank God you post the slides. Maybe you should have been slower so that we'll just assimilate some things, especially the common ones, atrial fibrillation, supraventricular tachycardia, then the heart blocks. You know, we're always saying that heart block a,
Yes.
a lot of the time in the clinic.
Mm,
So
yes.
know which one is benign, which one we don't need to panic the patient with. But overall, nice presentation. The-
Thank
I-
you,
I-
ma.
then I was thinking, so these presentations is also for us to be able to manage in our GOPD some common ones, or maybe in the emergency, even if we're called to the emergency. Like you put this clinical presentation as most of them have that mnemonic collapse.
Yes.
Do they have because the investigation you're trying to say for arrhythmias is as if you're just saying the investigation is ECG, but other causes of, you said there were so many other causes. So if you want to manage, when you say management, there should have been
Yes.
a slide to say, so in management of any arrhythmia, so you take a good history, and history will most of them will present with collapse, then good examination, then other tests, all the biochemistry
Yes.
tests. Okay.
EUC, FLP,
BMP, BMP, the cardiac
blood
enzyme.
counts.
Yeah.
Yes.
Mm, okay. Then what's the role of echo in cardiac arrhythmias?
The role of echo.
Yeah. It's not a big deal. It's not a big question. Who would you do echo for? Would you do for all of them?
And patients with other like heart inherent heart diseases,
Okay.
coronary artery disease, heart failure, myocarditis, elderly patients,
Cardiomyopathies. So,
cardiomyopathies.
so it means you may end up doing for everybody, because if you suspect it, you must do an echo, isn't it?
Yes.
And because cardiomyopathy, structural defects are causes of cardiac arrhythmias. If you suspect in this patient that, oh, this patient may be having, this may be one of my causes, it means an echo is important for almost all of them.
Yes.
Yeah, apart from maybe lone atrial fibrillation and your first degree block and the what's the other block that you said can just go away? Mobis, abi?
Mobits 1, that's second degree.
Second degree Mobis 1.
Mobits 1 and 2.
Okay. Okay, any other comments? Everybody, the house is
Yes,
quiet.
ma.
Okay.
Thank you, Dr. Ehireme. Ma, I
Okay.
don't know. I have a question. So, what do we do when a patient's results? Okay, a patient has like a first degree heart block, because I think that's what we commonly see in GOPD, knowing that it happens in healthy hearts. So, how do we go about it? Do we still, because I saw that she gave some example of some causes that can give I think first degree heart block, hyperkalemia, what else again? But so what do we do when we see first degree heart block? Do we reassure the patient and tell them it's one of those cardiac disturbances? Do we repeat the ECG after some time, or how do we go about it?
Ehireme, you want to answer?
So, first of all, you have to rule out all those. When you see that
Yeah.
a patient with such, you need to rule out, is it as a result of a heart disease, electrolyte in disturbances, you ask for signs and symptoms, increased vagal tone, all the causes, things that could cause the AV, first degree AV block. If you've been able to rule that out, knowing fully well that it's not something that will kill the patient. And also, patients who are hypertensive, have hyperlipidemia, want to make sure that their BPA, cholesterol, sugar, everything is under control. If you've been able to control all of that and rule out all the possible causes, and your patient is on the appropriate medications, then there's no extra thing you have to do for them, just to observe. And
Okay.
yes.
All right. So, which of them should we be concerned about that would need like an immediate cardiologist review?
Of course, once it enters the second degree AV block, you have to refer to the cardiologist. And
Okay.
when there's a complete heart block, that's an emergency.
Okay. And I sorry, one last question. That asystole, just a bit of clarification. Is it similar to what we see at cardiac arrest, or is just on its own?
Well, I don't think it's what is cardiac arrest in itself, because in cardiac arrest, both everything in the heart is not functioning. In ventricular asystole, it is the ventricle that is not working, not the atria is working, but the ventricle is not working. But of course, it's still an emergency, because if the ventricle is not pumping, therefore there's no cardiac output. But they are not exactly the same thing.
Oh, okay.
Is a form of is one of the forms of cardiac arrest.
Yes.
But they usually even say that asystole. Did you say it was treatable? I thought it was irreversible.
Well, they said you can institute CPR
Okay.
when that occurs. I didn't say it's treatable.
Well, we need to clarify something. There's something about I don't know if we've heard of non-shockable rhythms. There's something about asystole and not you can't do defibrillation. You cannot do a cardiac shock. But I'll check that out. Or whether you can do CPR, but you cannot shock. But we'll check. Sorry. I think, Doctor. Does anybody know what I'm talking about?
Yes,
We have.
I'm sure Dr. Ijoma will know. She just did ACLS.
I did. Oh, and Chief too. Chief just did too.
No,
Is it
don't call my name
pulseless
there.
reasoning?
They had there's no shockable rhythm now.
Is it pulseless electrical activity?
Pulseless
Because they said
electrical
some.
activity
Okay,
Yes. Good evening. Good
is not
evening.
shockable. There is electrical activity, you can't shock it.
okay. Then and that's the only one.
That's the only one I know. Pulseless electrical activity.
Okay. AC store. Okay. All right. So any more questions? Ehireme, so you're the expert. Anytime we have a challenge, we'll bring our ECG, our abnormal readings to you. And if they have a patient in